This meeting is being recorded.
So good afternoon to everyone, and welcome to our webinar on evidence-based practice on ivermectin use and COVID-19, a critical appraisal on systematic reviews and meta-analysis. So as we are giving some time for other participants to join in, we will be having a evidence-based practice on ivermectin use and COVID-19. The evidence as of now is inconclusive, and we have embarked in a trial to look at the use of ivermectin as a treatment for in the case of COVID-19. So even more recently, just early this week, someone posted saying that for the off-label use, patients you need to request from treating doctors for ivermectin. However, the Ministry of Health has refuted that claim, saying that the off-label use as of now it's only for clinical trials, not upon request. So um, the critical appraisal will be done by Dr. Mahler, Dr. Ang, and Mr. Ng. So what happens is that this, I would like to remind the audience, the attendees, that what we are doing today, it's a academically inclined exercise where we are examining the evidences that are currently available to us, and we will look into it deeply. So without further ado, I'd like to invite Dr. Mahler to start the ball rolling for the system for the critical appraisal. Dr. Mahler, over to you.
Thank you, Dr. Lai, for swiftly taking us through the journey of our global population along with the COVID-19 pandemic and on what has transpired and where we are now. So let us look into the objective of our presentation today. Dear participants, today we aim to emphasize on the importance of appraising scientific evidence in deriving rational judgments in our daily practices. Let us remember that in order to improve patient outcomes, we need three important components rather than irrationally coming into conclusions. The three important components are patient values and expectations, individual clinical expertise, and not forgetting best available clinical evidences. So, as Dr. Lai mentioned today, we are going to look into how we can derive into rational judgments based on best available clinical evidences. So now we will start going into the review of systematic reviews and meta-analysis of three studies we have chosen today. Before going deeper into each individual analysis, let us look into and highlight why we have chosen systematic review for our discussion today. We know that scientific information can be obtained from various sources, right from expert opinions up till systematic reviews. There are also case control studies, trials, and many more. But in the hierarchy of evidence, systematic review sits on the top of the pyramid. Why is that so? It is because of the quality of evidence. One method differs from another based on how the information is filtered. It is very important that when we review scientific data, we look into what is the data or information that has been input into the analysis platforms, because we must bear in mind if that's garbage in is only garbage out. So the quality of evidence is very, very important to be paid attention to. Now, why is systematic review special from the other type of sources of informations? Because here, when conducting a systematic review, authors usually, when there's an issue, they will identify the issue and determine the research questions. Thereafter, they write a plan on the review based on the protocol, and they search for relevant studies before sifting and selecting suitable studies. Only then they extract the data from the studies and assess the quality of these studies. Thereafter, they combine the data from various studies and look into whether or not a meta-analysis is needed. And then they will discuss and conclude the overall finding. And this is what comes out as a systematic review, because it's reviewed systematically and only then it's disseminated for the use of everyone else. So when we appraise a systematic review, it is important to keep in mind that there are several steps we need to follow. Mainly, we need to review the objective of the authors. We also have to look into their search strategies and methods, their inclusion and exclusion criteria, and we need to also review the quality of the primary studies that they have put in their results, and how the results were generated and reported, as well as the implication on clinical practices. So here we have chosen 3 studies, systematic reviews and meta-analysis papers, 3 studies. The first one will be by Roman et al., which was published in the Clinical Infectious Diseases Journal on the 28th of June 2021. The second study is by Bryan et al., which was published in American Journal of Therapeutics on 21st June 2021. And the third study would be by Hill et al., which was published in the Open Forums Infectious Diseases in July 2021. Let us take note that 2 of these studies, which is by Roman and Hill, looked into the role of ivermectin in treatment of COVID-19, and the second study by Bryan et al. Looked into the role of ivermectin in prevention and treatment of COVID-19. This session will be divided into 4 sections. The first section would be the overview, where we will discuss the objectives, main outcomes, and conclusions, as well as the PICO for each study. This Dr. Ang will explain in detail. As for the second section, it would be the search strategies and search terms, the inclusion and exclusion criteria, the risk of bias assessment for each study, the heterogeneity, and the third section comprised of the common outcomes measured in all studies, which is the all-cause mortality, length of hospital stay, viral clearance, and prevention of COVID-19. We also address other concerns in section 4, issues such as publication bias. Now let us look deeper into the individual studies. The next section will be conducted by Dr. Ang. Dr. Ang, over to you.
Thank you. So I shall continue from here. Okay. So as Mala has mentioned, we will start with an overview to see what each systematic review is about. So in here, this slide is just to give an overall brief understanding of each systematic reviews. What are their objectives? What are the main outcomes and the conclusions that the authors reported? So from here, we can see that all 3 systematic reviews are looking into the effect of ivermectin as a treatment for COVID patients. And in addition, Bryan is also looking into the efficacy of ivermectin in preventing COVID-19 infection among people at higher risk. But all 3 of them, they reported different results and also concluded in a different way. So Roman and all, they found that ivermectin did not significantly reduce all-cause mortality, adverse event, and viral clearance as compared to placebo or standard of care. And thus, the author concluded that additional ongoing randomized controlled trials should be completed in order to update the analysis. In contrast, Bryan et al., they found that ivermectin treatment reduced risk of death with a moderate certainty. And ivermectin prophylaxis also reduced COVID-19 infection risk by an average of 86%, although with low certainty, whereas the secondary outcomes provided less certain evidence. And Bryan concluded that moderate certainty evidence showed large reductions in COVID-19 deaths are possible using ivermectin. And with its use in early phase, ivermectin may reduce progression to severe diseases. And Bryan also said, since ivermectin is safe and low cost, it may have a significant impact on COVID-19 pandemic globally. So on the other hand, what did Hill found? Hill also found a reduction in overall mortality, and ivermectin was more favorable towards clinical recovery and reduced hospitalization. However, Hill concluded that this benefit needs to be validated in larger confirmatory trials. So in the subsequent slides, we will go deeper to see why 3 papers are reporting differently and why the differences. So to have a clearer picture of what clinical or research question these 3 systematic reviews wanted to answer, we will use this PICO tool. So PICO is a useful tool to help define a clear and focused question and also to develop a review protocol which includes the research strategy. So PICO actually stands for population, intervention, comparison, and outcome. From here, we can see that there are differences in the population. Roman focuses more on patients with mild and moderate COVID-19, whereas Bryan and Hill cover the whole range from mild to severe. And Brian, in addition, also covers people at high risk because they are also looking into prevention. In terms of intervention, all three were looking into ivermectin. But in terms of comparison, Roman restricted to comparison with only standard of care or placebo. Whereas Brian and Hill also allowed comparison with another active comparator such as hydroxychloroquine, with it or without azithromycin. And in terms of outcomes that they are looking into, we can see that all three had death from any cause or all-cause mortality as one of their primary outcomes. But Brian has additional few other objectives as their secondary outcomes. So this is, from here we know roughly what they wanted to answer and what type of studies they will be looking for. And PICO will help to develop the search strategy. And so next we will be going into their methods, how they conduct the search, what inclusion and exclusion criteria were used to select the studies to be included, how what was the result of their assessment on the risk of bias and the heterogeneity. So from this slide is about the search strategy. We can see that the search period are actually quite close by among these three. They are only about a month apart. Romans up to 22nd March, Brian till 25th of April, and Hill until 12th May. And they have covered more than 3 major databases, which is good. And they have also covered great literatures from other sources like the preprint servers. In addition to that, Brian and Hill also look for data or studies from the clinical trial registries and reference lists of other reports. So they didn't set any restriction on the language, and the search term used are also similar. So from here, we can say that the search is actually quite good. We do not expect major trials to be missed. So from this search strategy, the authors will have a list of clinical trials which are potentially eligible to be included in their reviews. So the next thing we will look at is the inclusion and exclusion criteria, which defines which study would be included and how they select the studies. So from here, we can see that all 3 reviews included only randomized control trials. So this is justifiable because randomized control trial is the gold standard designed to evaluate efficacy of an intervention or treatment. So this is the total studies that were included in all 3 systematic reviews. From here, we can see that Roman had included a total of 10 trials in his review, whereas Brian and Hill had 24 each. And as we know that their search period were nearby, so it is expected to see overlapping of trials included in the studies. So we can see that 9 trials were included in all 3 reviews, whereas Brian and Hill had 21 overlapping studies between the reviews. One thing we also note is that there are quite a high percentage of non-peer-reviewed articles or data being included in the reviews. So in the diagram, you can see the bold ones are those from peer-reviewed articles. But one good thing we see here is that majority of the trials were registered in clinical trial registries approved by the International Committee of Medical Journal Editors. So we also think that it would be interesting to see how the studies distributed by their results. So this is we drew this based on the results on all-cause mortality. The blue ones are those without significant results in all-cause mortality, or they have 0 events in both intervention and also control arms. Whereas the purple ones are the ones that showed significant results favoring ivermectin. So from here we can see majority there were more trials that showed non-significant results than the significant ones. Okay, now we have some idea about how many studies and what type of studies were included in the review. Next important thing that we need to know is the risk of bias assessment. Like what was mentioned by Mala earlier, the quality of the evidence depends on the quality of the primary trial. If the primary trial was not conducted well, the quality of the evidence can be downgraded. So garbage in, garbage out. From here, we see that all three reviews, they use the same Cochrane RCT risk of bias tool for assessment, but there were two versions used. Brian used the earlier version, whereas Roman and Hill used the later version. The difference between these two versions is that the newer version has an option to pull the overall rating for each study. So what was assessed during this risk of bias assessment is that they assess the risk, whether there is any high risk during randomization or concealment of the allocation, or whether there's any issues with blinding or measuring of their outcomes, any problem with the missing data or reporting the results from each study. So what we can note that is that there are very low percentage of trials with low risk in all these three reviews. So this would raise some concern about the quality of the evidence later. So besides the risk of bias, we would also like to highlight the variability in the treatment regimes used in each of the studies. So we have listed the treatment regimes for all studies included in these reviews. From here, we can see there were not only variation in the dosage, durations, and frequency, but there were also variation in the types of control they use. So in terms of dosage, there were fixed dose, there were dosage based on body weight, and frequency, there were some single doses, some were multiple doses over a different period of intervals. So the next slide was showed the similar information for the rest of the trials. So why is this important is that this could introduce, this could contribute to heterogeneity. What is heterogeneity? It is something which is important in systematic review that we need to note. It is any kind of variability among studies in the systematic review. It could be variability in the participants, the type of patients included, in the interventions, and how the outcomes were studied. It could also be the variability in the study design and the risk of bias. Why is it important? It is important because meta-analysis should only be considered when a group of studies is sufficiently homogeneous, meaning similar, in terms of participants, interventions, and outcomes, so that it could provide a meaningful summary. So usually in systematic reviews, heterogeneity can be assessed using visual inspection of forest plots or using statistical methods like I-square and chi-square tests. So in the slide, you can also see a rough guide to interpret I-square. The issue is that when there is considerable heterogeneity, one should consider whether meta-analysis should or should not be carried out. And when there is moderate or substantial heterogeneity, maybe subgroup analysis should be carried out to find out the cause for the heterogeneity. So with this information about the number of studies, the risk of biases, and the heterogeneity in mind, we will now proceed to the results section, which will be presented by Yithan.
Hi, thanks, Dr. Ang. I will take over from here. Good afternoon, fellow speaker, panelists, and audience. I'll talk about the results section by the three recent published papers mentioned by my colleague. Right. The primary outcome that I would like to highlight is the all-cause mortality. Looking into the first systematic review by Roman, the pool result from the left indicates that there was no sufficient evidence on IVM efficacy in reducing the mortality among people suffer with COVID-19, regardless of severity, by having the risk ratio of 1.11 with the confidence intervals of 0.16 to 7.45. The author also conduct stratify forest spot according to the disease severity. And what they found out that there are also inadequate evidence for the IVM to protect against the mild symptoms COVID-19 patient with the risk ratio of 0.28 and the confidence intervals from 0.04 to 1.80. So generally, the authors rated the quality of the evidence as very low. Moving on to next slide. On the other hand, Bryan et al. Found that there was an overall reduction in mortality among the IVM treated patient in comparison to the control group, which is allocate about 62% of reduction. When we look into the forest plot carefully, noted that there was an inconclusive evidence among the severe patient, which have the risk ratio of 0.51 with the confidence intervals of 0.22 to 1.14. However, the team stated that IVM can protect patients with mild and moderate COVID-19 infection with a reduction mortality of 76%. In an overview, Bryan summarized that their findings had moderate quality of evidence. Similarly, Hill et al. Also showed that there was an overall reduction of 56% in IVN arm in comparison to the control group. However, there are only sufficient evidence to show IVM is beneficial to the mild and moderate group COVID-19 cases with a mortality reduction of 70% and the confidence intervals of 42% to 85% compared to the severe COVID-19 patient, which is have the risk ratio of 0.58, but the confidence intervals crosses 1, which is 0.25 and 1.32. Basically, this table summarized that all-cause mortality across these three studies. As a recap, Roman stated that IVM did not have sufficient evidence to reduce mortality among COVID-19 patients. In contrast, both Bryan and Hill showed that IVM can reduce the overall mortality, especially among patients with mild to moderate COVID-19 infection. Okay, now moving on to the secondary outcome. All three studies summarized that there were no significant reduction in length of hospitalization among IVM and control groups. Although Roman and Bryan, which only include one of the study, rated their findings as very low quality of evidence, Hill paper include significantly more study with higher numbers of audience patient, and they obtained the similar finding with the mean difference that crosses 0, indicate there are no difference between the control and the IVM intervention arm in terms of hospitalization. Now, moving on, regardless of the viral clearance, only Roman and Hill presented this information. The pool result on the viral clearance in terms of proportion from Roman study showed that, again, IVM has no sufficient evidence in reducing the viral load among patients with the risk ratio of 0.96, but the confidence interval including ones as well, which is 0.82 and 1.13. The author alerted the reader about the low quality of evidence in their study anyway. Moving on the other hand, Hill's paper revealed that IVM can effectively reduce the time of viral clearance, especially for those multi-day dosing, with a reduction of average 3.74 days, with the confidence intervals of 5.77 days and 1.72 days. Single dosing of IVM was also able to reduce the time to viral clearance of the with the average of 0.74 days and the confidence intervals of 1.4 to 0.09 days. Overall, the pool results show that IVM can significantly reduce the time to viral clearance by average of 3 days. Now, moving on, this slide basically summarized the interpretation by the authors. Briefly, Roman stated that generally there were no sufficient evidence to prove IVM is effective against COVID-19 viral clearance. In contrast, Hill findings state that it's effectively to reduce patient viral load. However, the audience have to note that due to the high heterogeneity among the RCT, including especially the multi-days dosing and the pool result, the reader should interpret the result with extra caution. Moving on. For the prevention of COVID-19, only Bryan et al. Presented the use of IVM as prophylaxis. The authors showed that IVM can prevent COVID-19 infection by as high as 86%, with the confidence intervals of 79 to 91%. However, I would like to address some issue about this outcome. First, the included RCT was rated as high risk of bias due to the flaw of design, particularly on the random sequence of generation and the allocation of consumer. In addition, the existing variability of dosing regime resulted the low quality of the evidence in the pool result. Hence, we have to be extra careful while interpreting this result, even though the author showed that IVM is effective in preventing COVID-19. Moving on, the next section, I would like to highlight about the possibility of publication bias and other concern about the systematic review paper as mentioned. Generally, there are no noticeable publication bias by Bryan and Hughes et al. Because there was an equal distribution between included study within the funnel plot. However, Roman et al. Didn't present the funnel plot, therefore there's a limited evidence to justify whether there's a publication bias for that paper alone. Next, moving on. About conflict of interest, there were generally no conflict of interest by all three publications. However, there was a discrepancy between bias risk assessment. As when you're looking into the table below, out of 9 overlap study by Roman and Hugh, only 4 out of 9 which rated the same. This suggesting there might be a judgmental bias across author from different publications in assessing the RCT quality, even though they are using the same instrument, which is Cochrane Risk of Bias version 2. Last but not least, it should be noted that all publications, including grant literature as highlighted by Dr. Ang just now, inclusive of preprints, unpublished data, which is not yet officially recognized in review. I believe that till today, many of us are aware about the latest news of the preprint study, which was retracted from the preprint server due to an ethical concern, which will be addressed after the summary by Dr. Mala. I'll pass back to you, Dr. Mala.
Thank you, Mr. Yithan. Sorry about the technical issues regarding the sound quality earlier. I hope you all can hear me now loud and clear. So a lot of information has been shared. Dr. Ang and Mr. Yithan has nicely dissected each systemic reviews and given us a lot of information. But what usually happens when there is a lot of information, sometimes we tend to drown into oceans of information. So don't worry, we have put a box, a table here to summarize and put back into perspective on the summary of findings for all 3 studies that we have highlighted here. So we have divided it into 3 components, which is the main outcomes reported, limitations identified by the authors themselves, and what is the conclusions by the author. So in summary, the study by Roman et al. In 2021, they reported that ivermectin did not significantly reduce all-cause mortality, with a relative risk of 0.37 and a confidence interval of 0.12 to 1.13. This shows its very low quality of evidence. So here, when we speak of confidence interval, the cutoff point is 1. When it crosses 1, it means the results are not significant. So the adverse events and for viral clearance, it also showed low quality of evidence as compared to the placebo or the standard of care group. Hence, the authors has identified some limitations in a few areas. Firstly, in terms of quality evidence, it was either low or very low for all outcomes measured. In terms of risk of bias, they realized that 8 out of the 10 randomized controlled trials that they have included in this review has a high risk of bias. And in terms of number of participants, it was also relatively low. If you can recall, it was mentioned earlier that for this systematic review, about 1,173 participants were included as compared to the other two reviews where there were about 3,000 participants. And even in terms of follow-up time, 4 out of the 10 RCTs had only a follow-up duration of 5 to 10 days. Hence, here, the authors concluded that additional ongoing randomized controlled trials should be completed in order to update the analysis. Now, let's look into the second review by Brian. The main outcomes, they reported that ivermectin in fact reduced the risk of death with a relative risk of 0.38 and a confidence interval of 0.19 to 0.73. However, this was an evidence of moderate certainty. In terms of preventive or prophylaxis management, the usage of ivermectin in COVID-19 patients actually reduced by an average of 86%, with a confidence interval of 79 to 91%. But of course, they mentioned this here, the evidence was of low certainty. And for the secondary outcomes, it provided lesser certain evidence. Here, the authors have identified a few limitations. In terms of risk of bias, they realized that several studies did not provide full description of the method. So they had challenges in assessing the risk of bias. In terms of management and regime of care, there were noticeable variability in treatment regime among control groups. And in terms of dosing of ivermectin, and there were also involvement of other components of care in the standard care, and this requires further research. So in this study, the authors concluded that ivermectin is significant with moderate level certainty of evidence in showing large reductions of COVID-19 deaths. And using ivermectin in early phase of the infection may reduce disease progression in terms of severity. However, in terms of safety, and since it's low cost, ivermectin may significantly impact on managing COVID-19 pandemic globally. In the third study by Hill et al., it was reported that ivermectin reduced about 56% in terms of mortality with a relative risk of 0.44 and a confidence interval of 0.25 to 0.77. This is among patients with moderate and severe infection. And they also realized that ivermectin was more favorable towards clinical recovery and reduced hospitalization among COVID-19 patients. Here, the authors identify some limitations in terms of variations in treatment and control, such as in terms of dosage and duration of medications, as well as usage of other drug components like hydroxychloroquine, lopinavir, and ritonavir was used in combination with the placebo or standard of care. Also noticed was the standard of care and the control arms differed in between individual studies that were included in the trial. In terms of populations, there were variations in the inclusion criteria of individual studies. And in terms of outcome measures, it was not standardized. Like, for example, viral clearance was measured, but it was measured at different point of times in different studies that were included in this study. So here, the authors concluded that despite ivermectin being found to be beneficial, it needs to be validated in a larger confirmatory trials. Now we have received a few questions from you all, like different studies have different conclusion. What do we follow? Do we or do we not? Now, let us here highlight to you, this is where it is very important to realize that these conclusions that is presented here are authors' conclusions. They are individual conclusions based on the research and studies that they have conducted. But this is where we might want to notice that it may vary across studies. So this is where our ability to judge rationally based on the evidence that they provide and the quality of evidence that they have involved, so that we can make rational judgment comes in. So, dear participants, here we would like to highlight a few take-home messages based on the presentation we have just made to you. That the quality of evidence from systematic review actually depends on the quality of studies included in the review. So, looking into adequate evidence is a prerequisite for a drug to be registered for use. For example, most countries, they actually require large confirmatory studies or studies which are on phase 3 or phase 4. Like in Malaysia, we need to ensure that the study is of good efficacy, safety, and quality, and the study needs to be a phase 3 of quality. Here in Malaysia, we have started in May, so let us also wait and see what is the outcome of the study. Ultimately, we advocate critical appraisal of the available evidence rather than solely accepting recommendations of authors, as we can see earlier in the previous slide, because it may potentially mislead the public and also the entire healthcare system. This is very important because I think by using a good evidence cycle of evidence-based practice, we may be able to act and assess appropriately. So when there's a dilemma, of course, we have a lot of questions in our mind. We ask a lot of things and we acquire a lot of knowledge, but it's important to appraise those information critically before applying them to the entire population. And even after applying them to the population, we need to assess its implication and outcome to our population as well. So dear participants, I believe all of us are working in the highest interest of the best outcome for all the entire population. Let us also take into consideration that the disasters are currently collaborating better than we are. We are not just facing with the pandemic alone, but there is issues of climate, internal conflicts among nations, depleting economic status, and these are all issues that may impact on our overall quality of lives. Hence, the current and future generations depend largely on the decisions we make today. We must remember that we are all in this together with a common interest. And evidence-based practice is one platform to take us all in the same boat. We are all in the same boat. It is important to bring us into the right directions instead of going on various directions with no clinically proven outcome yet. So here again, we are not advocating on whether or not what should be used and what should not be used. We are advocating more on rational judgment made based on proper evidences available. With that, I'll get back to Dr. Lai. Thank you.
Thank you so much, Dr. Mala, Dr. Ang, and Mr. Ng for the very detailed and thorough presentation on all the evidences available to us currently. And as of today, this morning, there are also some new, very, very recent updates across the world. So I would like to invite Prof. Moy to elaborate more on what is the latest update as of today. Over to you, Prof. Moy.
Thank you, Dr. Lai. And thank you, the speakers, for making a very comprehensive review of the systematic reviews. So early this morning, we received news that one of the larger trial with positive result, that is Algaza trial, was retracted from the preprint platform due to unethical concern. So this is not the platform to discuss why it was retracted, but if you are interested, you can refer to these few write-up that you can access from the website. Can I have the next slide? So what we did was, if it's retracted, we remove the numbers, the findings from Algaza study, and we rerun the analysis. So if you remember well, the previous results, I think only the Bryant and the Hill reviews had Algaza involved in the meta-analysis. So we reanalyzed Bryant's meta-analysis by removing Algaza study. We still have positive results with the relative risk of 0.54, meaning that the all-cause mortality was reduced by 46%, but the 95% CI was 0.31 and 0.94. So that means that as low as 6% of reduction in mortality. Okay, so this result shows that it is closer to the null, that is 1. okay, with the removal of Algaza's study. Next slide. So for Hill, we did the same, removing Algaza's findings. We also have the results to be closer to the null. That is, the point estimate is still positive. That is 0.58 with the 95% confidence interval of 0.34 to 0.97. So compared to just now, without removing this study, can we have the next slide? Okay, so here we present to you the original results with Algaza's findings included. So Brian's result was 0.38 with the CI of 0.19 to 0.73, and the p-value was highly significant, 0.004. Whereas Hill's studies, Hill's review gave a relative risk of 0.44 and 95% CI of 0.25 and 0.77 with a very high p-value as well. So after we remove Algaza's trials, which was withdrawn from the we find that the point estimate has reduced from 0.38. It has reduced to, I mean, it increased to 0.58, meaning that the protective effect has reduced. That is from 62% to 48% in Brian's study, and in Hill's study from 56% reduction of mortality to 42% reduction in mortality. So if you look at the confidence interval, it is also closer to 1, the point of no significant, no statistical significance. And when you see the p-values, and is greatly reduced, 0.03, which is very close to 0.05, the cutoff that we used to we usually use. Okay, so is there any more slides? No more, right? I think this is the point that we want to bring out, that when after we remove these large clinical trials with positive results, the pool results of the effect of ivermectin on all-cause mortality has actually reduced, and the evidence is it is even less, there is even lower. So we do need more larger and well-planned clinical trials before we can make further decision on this drug. Yes, thank you. I think that's all from me. Thank you.
Thank you, Prof. Moy, for the elaboration on the current update that we have received today. So now we would like to move on to the next segment, which is on the forum and Q&A. So we are very privileged to have Dr. Zainal, who has been very busy lately, and then he's able to find time to join us for the forum today, as well as Prof. Dr. Sanjay Rampal, and then also Prof. Dr. Moy. So I'd like to introduce a bit about Dr. Zainal, who is currently a public health consultant and the president of Malaysian Public Health Medicine Specialists Association. And over the 35 years of his service, he has held many or various positions in the Ministry of Health, last of which was the director of Pahang State Health Department. And then he has also served as a medical officer and temporary advisor in the field of non-communicable diseases and diabetes at WHO Western Pacific Regional Office. So despite being retired from civil service not too long ago, he is still a very active public health activist. And moving on to Prof. Dr. Sanjay, he's a professor of epidemiology and public health. He chairs the National Conjoint Committee for Public Health Postgraduate Medical Program Malaysia. He is also a member of various international associations such as International Epidemiology Association, American Heart Association, American Stroke Association, and Society for Epidemiology Research. So, and he has been also an executive member for the College of Public Health Malaysia Medicine since 2016. And last but not least, Prof. Moy is a professor in the Department of Social Preventive Medicine, Faculty of Medicine in the University of Malaya. She teaches epidemiology, research methodology, and evidence-based medicine to both undergraduates and postgraduate candidates. She's the coordinator for the Master of Public Health program, and she's also the coordinator for the University Malaya Network site of Cochrane, Malaysia. So we will get the ball rolling with the first question that will be directed to Dr. Zainal. The question would be that what is off-label use?
Yeah, so Chairman and colleagues and also participants for this webinar. First, I'd like to congratulate the participant presenters. Very comprehensive and very good presentation. I like actually the prize also. Okay, for the question, the off-label is actually this term used for drugs that have been used, going to be used. It's not as indicated as in the first what you call prescription, or as the first intended to. Sometimes people say a repurpose of the drugs. Yeah? For example, this we take this Ivermectin. Actually, the Ivermectin is used for antiparasitic drug for for animals, but people tended to use for human, so it's called off-label and then repurpose. But one thing for very very important for repurpose or for the off-label use, the medical practitioner can use these drugs in two conditions. Number one is for approval for a certain approval for example, a trial or for investigation, further investigation. And number two, if you want to use the off-label, you must be some sort of a consensus from authority or a body. For example, if everybody is in the field, in the medicine field, agree to use this off-label for whatever indication, so you can use. But if not agreeable by the consensus or by any authority, so you cannot use this off-label or repurpose for your patient. So this is the meaning of off-label drugs. Yeah.
Okay. Thank you, Datuk, for the extensive and comprehensive explanation of what is off-label use. So I think the next question is a question of very great concern to the public, especially that is Ivermectin available in the market, and is it safe for human use? That would be a question to you, Prof. Sanjay.
Thank you, Dr. Lai. So basically, ivermectin cannot be prescribed by a doctor, and it's not available for purchase through the legal supply chains. So no formulation is approved by the National Pharmaceutical Regulatory Authority or registered in the Malaysian formulary. So basically, even though the doctor may want to prescribe, he cannot in a legal sense. Now, it's important to note that the MOH may have likely used a clinical trial exemption or clinical trial import license for their clinical trials. So any medical doctor or any organization who's interested in a clinical trial on ivermectin can do so, actually. However, you would have to apply to the NPRA for either a clinical trial exemption or a clinical trial import license. Now, that being said, once we've already gone through the legal channels, ivermectin may be available online and being illegally sold by various parties. Now, there are issues with purchasing medicines online, I think, and this is very important. So number one, it is illegal primarily to safeguard our health. So you're not sure of the manufacturing quality of whatever substance you're getting from online sales. You are actually unsure whether it was diluted or whether it's fake. It could just be sugar pills given to you. In addition to that, there's actually no agreed on set dose. And I'm coming to dosage later on, but I will put forward now that whatever doses being sold may not be the appropriate dose to be used for ivermectin. Thank you, Dr. Lai.
Thanks, Prof. Sanjay. Just for the benefit of the audience, NPRA is the National Pharmaceutical Regulatory Agency. So it is something like the equivalent of the FDA for our country in Malaysia. So while we are on this, the further question would be, what are the side effects of ivermectin? Prof. Sanjay, if you don't mind, would you like to elaborate that?
Sure, Dr. Lai. Now, one important point about drugs is all drugs have side effects. It's just whether we know of it or not, right? So the estimated adverse drug reaction to ivermectin from a WHO database, it was estimated at 11 adverse events per 1 million dosages, per 1 million treatments. There's a large variety of possible adverse events. Now, that being said, over 1 billion treatments of ivermectin has been administered in the large-scale preventive chemotherapy programs that was done against lymphatic filariasis and onchocerciasis. Now, the point to note is, during those treatments, different doses was used. And typically, it was a single-step dose. So many of these treatments that ivermectin was used, it was a single dose of ivermectin given, and that's it, right? So the incidence of adverse events during these large treatment programs were actually classified as minor and transient. Now, coming back to the dosage, and this is important because the safety profile would change if higher doses are required and at more frequent intervals for different indications. So remember that the information we have, the safety profile we have, is for ivermectin use in its traditional indications. So I would say that the safety profile for use as an antiviral, more information is needed. Thank you.
Okay, thanks, Prof. Sanjay. So then the next question would be, what is WHO's stand on ivermectin use? So Prof. Moy, would you be able to elaborate more on this? Thank you.
Thank you, Dr. Lai. Currently, the WHO issue guidelines against the routine use of ivermectin in the treatment, except in clinical trial setting. So currently, we do have a clinical trials running in Malaysia, in UK, and so on. Besides WHO, the FDA from US and the EMA from the EU, they also concluded that there's insufficient evidence to support the use of ivermectin as a treatment of COVID-19. Yes.
Okay. Thanks, Prof. Moy. So as mentioned, that the point here is that at this point there are insufficient evidences. But how useful are the meta-analysis and the systematic reviews in providing evidence for the use of ivermectin in COVID-19, that the exercise that we have just done?
Okay. Yeah. I would like to, before I give my answer, I would like to describe the difference between a meta-analysis and systematic review. So actually, meta-analysis is statistical methods that we combine all the results of several independent studies and to give a pool results across the studies that are combined. So the meta-analysis must be done in the context of a systematic review in order to provide reliable results to inform clinical decisions. So a good systematic review can provide reliable results that change practice and policies. So when do we use it? When is it useful? It's useful when we have a lot of trials giving inconclusive evidence, meaning that we see that the current trials from ivermectin on COVID, some are positive, some are no effect, and some are negative. So this is when we need to do a meta-analysis. And there are controversials with regards to treatment. The balance between benefits and harm are not clear. And a systematic review is also one that we do when we want to plan a new trial. If there's sufficient evidence, we don't need to do another RCT, all right? So, so the results need to be interpreted cautiously, as is summarized just now. So we need to look at the risk of bias, the heterogeneity, and then the point estimate, including the confidence interval, which we have gone through just now. Yeah, that's all I have to answer for meta-analysis. Thank you.
Thanks, Prof. Moy. That was mainly on the methods that people are trying, or the not just the medical fraternity, but the public are also looking into all these evidences that are coming out. They are very recent, they are very fresh. So that was the explanation for the technique that involved in coming out of all these articles. So meaning what about the effectiveness of this? Meaning to say that while looking at the evidences available now,
Okay,
how
thanks.
effective is it in?
So based
Go ahead.
on the results just now, right? Based on the results from the systematic review, they seem to have positive results in reducing mortality, but the evidence is not conclusive due to the confidence interval is pointing to the null value. So for this kind of results, we would think that the evidence is insufficient, and we need larger, well-planned RCTs. So if you ask me how effective is the use, I cannot give this answer because I would need more evidence to be convinced of the effectiveness of ivermectin in treating COVID. Thank you.
Yes, thanks, Prof. So the next thing would be that how do we determine the appropriate dosage for repurposed drugs? I think this was what Prof. Sanjay had touched briefly. So would Prof. Sanjay be able to explain more for us? Thank you.
So typically for any drugs, right, to determine the dose, we do what is known as a phase 2 clinical trial, right? So in phase 2 of a clinical trial, there's dose determination. And what we then do is we explore different doses and monitor the safety profiles and a bit of efficacy of these different doses before determining an appropriate dose to further test. Now, so the first thing we have to do is we have to determine a dose, right? After that, in phase 3, and this is important, I think, because we are talking about meta-analysis, and meta-analysis has gotten a good rapport because it pools together studies. But it's important to note that when you pool together the studies, you want high quality studies. Now, what do I mean by high quality? That means studies which are less susceptible to bias, right? And how do we get the studies that are less susceptible to bias? And bias can be all sorts of bias. Now, the point is, we typically do for drugs, for any drugs, we do phase 3, what we call a phase 3 clinical trial. So we usually accept 2 large confirmatory clinical trials that rigorously follow good clinical practice guidelines. And GCP guidelines are very important to ensure that the results that comes out from these trials are valid. So the application should also contain necessary documentation. The protocol should include capacities for independent safety monitoring committees. There should also be independent audits to verify quality and veracity of the data. Then there should also be additional quality checks put in, like a screening log, like a randomization schedule, a written informed consent, so on and so forth. The main thing to point out here is typically to get good evidence, we need to run high quality studies. And one issue that I have with the amount of quality we have, I think that the results, following up with what Prof. Moy said, I think the results are suggestive. There is a suggestive effect of ivermectin. However, the quality of the studies are very poor. And so what happens is it's possible that the results were affected by bias, and that's what we do not want. And that's why we need 2 large, at least a large, high quality confirmatory clinical trial to decide on this research question. Thank you.
Thanks, Prof. Yeah, I think one of the highlights is that any decision made at the ministerial level, it affects the whole population of Malaysia. So though it seems very easy to treat at an individual basis, doctor to patient, but at the population level, we just have to be a bit more cautious. So then that begs the question to Dr. Zainal, that why is ivermectin not used in Malaysia?
I think, okay, this is very important because, after, there's a lot of debate in public, in the professional, and not only in our country but also in the global platforms. But the most important thing, because if you want to give something for the population as a policy of the government, you must be very sure about one is the safety, number two is the efficacy, and then later on is what the cost, whatever this one. But from this, most of the studies that we have, I think I like to quote here, the three what they call meta-analysis is very recent and very important for actually to this debate of Ivermectin. And for today, until this morning, we have some, you can see some greater positivity in terms of Ivermectin. But because of this morning, and then you take out the Azaga research, so the it's less, or weak, very weak in terms of positivity of the efficacy. So I think for the government, I think no, for sure, first we should have something that based on the very valid, solid evidence of the safety and efficacy. And at the moment, it's not there. So definitely, as a government, we cannot, we cannot prescribe or cannot make a policy that we can use these non-based drugs for the population. So that's why, like.
Yeah, thanks, Dato. I think, as you have mentioned, meaning imagine if back in March we approved hydroxychloroquine, what the consequences might have been, may not be as what we as practitioners intend for our patients, particularly our friends and family, because later on it was rescinded, not to be used later on. So I think once again, all of us are in the same boat on this. People want the best for everyone, but now that the cases have gone high, and then it has created a lot of anxiety among the populations and practitioners alike. So the question would be, what can the doctors do while waiting for more conclusive evidence and all to change the direction of this pandemic? So Dato, would you like to enlighten us on what can we do as of now?
Okay, for doctors with Ivermectin, I think we have to wait until we've got very good evidence coming from the last trial or from the Ministry of Health trials. And number two, as a public health intervention in any epidemic or any outbreak, first we go for the public health intervention, and then later on with the chemoprophylaxis, like if we have. So in terms of this pandemic, I think we should stick and strictly follow these public health intervention. Number one is all these SOPs, distancing, masking. Number two, we follow the next very very good tools in terms of intervention in the vaccine. So now, although people say okay, the efficacy is about 90%, whatever it is, but this is the best tool that we have now. So we go for the vaccination as far as wide as possible. And third thing, later on, if we have something like whatever prophylaxis, and then we can use. But at the moment, we stick into these two very proven, very effective: the public health intervention in terms of SOP, and number two is in vaccination. Yeah, we do that.
Yeah, thanks, Dato. I think you have also highlighted about vaccine. As of now, the recent data for the past 4 days, we have been able to meaning 400,000 jabs were given over the past 4 days. So yes, I think the role of vaccine is definitely not to be taken lightly, as it is a major and important game changer in this pandemic. So those are the questions that we have been able to compile from the registration early on. But now we'll move on to the last 15 minutes. We'll move on to live Q&A, where some of the questions from the Q&A chat box are elicited. So one of the questions would be, can you explain the case of India where COVID cases collapsed or reduced dramatically after the introduction of Ivermectin and well before the vaccine rollout? So would any of the panelists like to take that question?
I can take it. So thank you for that question. And we see this happening a lot with many other phenomena. So this is known, actually, to me, it's a correlation, right? That there was a large wave in India. We also have waves. There's increases in incidence, increases in new cases, and then there will be a drop of these new cases, right? So basically the pandemic propagates in waves. So there'll be increased number of cases, then it drops for a while, and then there's another large increase and it drops. And even in India, they're expecting another large wave in the coming months. So the question about ivermectin use is, number one, it could have worked. We must always acknowledge in science we are blind. We evaluate the evidence. Number one, it could be due to ivermectin. Number two, it just could be due to chance. That means there were other forces at play in India, like the lockdown, like the other NPIs, the other non-pharmaceutical interventions that the Indian government took, and other interventions done by the medical fraternity in India that actually resulted in a reduction of cases. We should also consider that maybe that outbreak burnt itself out. Maybe there was an outbreak among localized clusters, which are widespread, but they're localized clusters. And due to the intensity of the infection, it burns out, as in because a lot of those people in those localities get the infection, then they become less susceptible to the disease and infection actually comes down. So it could be due to any of these 3 or 4 reasons that I've given. Thank you for that question.
Yeah, thanks, Prof. I think one of the important phenomena in science, it's correlation versus causation. So when things happen together, it is important for us to decide whether it is correlation or causation, because that will affect our judgment. All right. So the second question would be that, sorry, I have a glitch here. Okay. Yeah. Second question would be that, what are the chances of ivermectin being deployed as emergency use in the current situation? Because cases are going up, people are anxious, despite the traditional process where what Prof. Sanjay has elaborated. So what about being deployed as emergency use? So maybe Dato' Zainal, would you like to explain that to us?
Yeah, I think at the moment, because our public health intervention, plus later on with improve or enhance coverage of immunization, these two methods or two approach, we've been, some sort of, we can control this pandemic. So yeah, we need some what called maybe like I meant to use for emergencies. But at the moment, I think we can wait for this really a positive positive result from whatever trials later on. So it's better safe at the moment, and as well as we have the very powerful approach in terms of public intervention and the vaccine for controlling this pandemic. Yeah.
Thanks, Dato'. So we have a very interesting question that has meaning looking at the fourth industrial revolution that we are entering, or has some country has already entered. The fact that, is there a possibility of applying artificial intelligence (AI) for drug repurposing against COVID-19? It's something that's very interesting. Prof. Moy, would you like to help us get a better grasp of this? You're muted, Prof. Sorry.
I'm sorry, I don't think there is a way to apply AI for drug repurposing. I really cannot think of how it can be done. I'm so sorry.
Yeah, I think that's one of the complexity of the pharmacology, particularly because in humans, the same drug, the same dose may have different effect in different individuals. The same antihypertensive may work for individual A that may not work for individual B. So as of now, yeah, it is still, maybe it's something that we can look into the future.
I think the
Then-
issue with, if I may interject, the issue with AI is you need data to run the algorithms, right? So the problem right now is, and the problem with data is you need good, valid data. So at the moment, we do have studies. We do have a suggestive association. Actually, we do have a positive association. However, the quality of the data is an issue, right? So even to do AI, I think the first thing we have to do is we have to collect good data. We have to collect high quality data, and then only can we let the algorithms loose on the data. Because if you run an algorithm on dirty data, it will run, it will predict, but it will just be biased. Thank you.
Thanks. So then another question is that from Brian 2021, meaning practically comparing from Brian and Hugh, IVMs, meaning ivermectin, significantly reduce death if given in early stage of disease. So whereas the current, meaning in comparison with our current study, which is looking at patients with stage 2 and stage 3, meaning the question is that why is that so? And then, yeah, rather than stage 1. So would any of the panelists like to elaborate more on, yeah, the slight difference in terms of the patient population that were chosen?
Dr. Zainal?
I think it's very, Brian and Hill, I think, because the one single entity that make a difference, what you call this Yoni is this is Al-Gaza research, because both using this study at the moment, we have to really see the detail of the study because it's really have an impact to this meta-analysis. So, and then this is the only study which study in terms of prevention of the risk groups. And if we don't have that, like Prof. Moy and Sanjay mentioned about the poor quality of the primary data, so this is very, what you call, very serious, before we can infer into population. Yeah.
Thanks, Dato. So I think that's more or less the part where we tried to examine the evidence available, and then and also go through the concerns of people on some of the matters around this ivermectin use in COVID-19. So I think with the benefit of time, meaning in view of the interest of time, so the last one would be that that because as of now, people are there are many pressures and calls from the immediate use of ivermectin. So like what Dato has highlighted about the what can healthcare professionals do at this point is once again to go through the public health measures that has been reiterated over and over again, and then and vaccination is definitely important in this pandemic, so which has good evidence as of now. So I would like to thank the speakers for the elaborate explanation, as well as the panelists who have tried to answer some of the concerns that were raised. And I would like to just thank all of you, the audience also, for coming in to listen to unbiased appraisal of the evidence available as of now. So thank you, everyone, and have a good weekend.
Okay.
Sorry.
The poll.
Yeah, the last one is the poll. So we had a poll earlier on. So I would like the participants to also answer the poll, and then we'll review the result of the poll. So I will launch the poll now. It will be 2 minutes